Welcome everyone to Medical Grand Rounds. We'll get started. Just before I present our speaker, just a brief reminder to please leave your questions till the end of the presentation. Please enter them in the chat. As well, please answer a brief survey that will be sent to you at the end of Grand Rounds, and this will let us know that you were present today. So it is a great honor and privilege to present my colleague and friend, Dr. Patrick Lawler, who has recently moved here from Toronto. He's the newest recruit in the Division of Cardiology. So very excited to have Dr. Lawler here. He is a cardiologist and clinician-scientist at the Peter Munk Cardiac Centre in Toronto, where he's the Associate Director for Clinical Trials and Translation. He's also an assistant professor of medicine in the Division of Cardiology and Interdepartmental Division of Critical Care Medicine at U of T. He attended medical school at McGill and completed internal medicine residency training at the RVH, so he's known to many of you. This was followed by clinical training in cardiovascular and critical care medicine at the Brigham and Women's Hospital and at the Mass General and at Harvard. He holds a master's degree in public health from Harvard School of Public Health. His research interests lie in the intersection of acute cardiovascular disorders and systemic critical illness, and employed clinical trials, clinical epidemiology, and translational methods. This work extends his research training in preventive cardiology, inflammation, and metabolism at McGill and the Brigham. So to continue, cross-cutting themes in his research relate to individualization clinical care through biomarkers, clinical staging and disease subphenotyping, as well as using systemic systems medicine approaches to drive drug and diagnostic discovery in critical illness. Since 2017, his research has been funded through a total of over 25 million from the CIHR, the NIH, the province of Ontario, Philanthropic Foundation, and others. He has led research published in the New England Journal of Medicine, JAMA, European Heart Journal, Circulation, Intensive Care Medicine, and others. He holds a National New Investigator Career Award from the Heart and Stroke Foundation of Canada, and he has just recently joined the Department of Medicine. He hasn't started yet, but I think you are starting in April, right, Patrick?
That's right.
He's a clinician-scientist in the Division of Cardiology and an attending staff physician in the Coronary Intensive Care Unit at the Glen and the MGH, and coming in as a McGill assistant professor. So needless to say, we are thrilled to have Patrick not only as a new colleague, but as a speaker today. I think this is a great way for everyone to get to know Dr. Lawler. So Patrick, the floor is yours. Welcome.
Thanks, Nadia. Thanks so much for such a gracious introduction. I guess, as Robert Frost says, home is the place where when you go back to, they have to let you in each time. So it's nice to be welcome back. I'm just going to share my screen here, and I'm going to switch it to the presenter mode. Okay, is it projecting as the slides?
It's not presenter mode right now.
It's you're not seeing the slides moving forward?
We don't see it in presenter mode.
Do you see my disclosures?
No, we just see the slide.
Okay, let me try another way of doing that then. Okay, take two. Disclosures?
Perfect.
Okay. And the next slide. The disclosures are talk, but they're all the kinds of things you expect to see. And don't send. Okay. Okay, using the objectives?
Yes, we are.
Okay, thanks. I just want to make sure. No matter how many times I do this on Zoom, I still feel like each time is the first time when I present. But again, as Nadia sort of graciously highlighted, it's really a privilege to be back among so many friends. And I've been watching the names of the people entering the chat, and it really gets me very, very excited to be joining the people that really inspired my interest in medicine and my enthusiasm for cardiology and internal medicine. So thanks for the privilege to join you overall. Thanks for the privilege definitely to join you today. The objectives that I was hoping to cover are to think about how an evolving understanding of acute disease heterogeneity could necessitate different emerging approaches to evidence evaluation, to review Bayesian adaptive platform trials in particular as sort of the solution to some of those challenges, and then to talk about heterogeneity treatment effect and how we can account for it in clinical trials. So I wanted to bring the narrative, what feels like way back to 2017 to 2019 after I finished my training. At the time, we were sort of finishing my training and looking at patients at the bedside and really sort of appreciating, I think, increasingly so, the diversity of some of the patients that we were sort of encountering in critical care settings. So I wanted to start out with two quick clinical vignettes. The first is a patient with cardiogenic shock. It's a 56-year-old man who's had an anterior STEMI, cardiogenic shock, cardiac arrest. He's cold on exam, has a low cardiac index, a high systemic vascular resistance, a narrow pulse pressure, multi-organ dysfunction, and requires moderate vasopressors and inotropes. A percutaneous mechanical circulatory support device is placed, and the patient improves over the next few days. In contrast, patient B is also 56 years old, also an anterior STEMI with cardiogenic shock and cardiac arrest, but this time the patient's warmer on exam. Their cardiac index is still low, but it's a little bit higher. And systemic vascular resistance this time is quite low. The pulse pressure is wide, but they still have multi-organ system dysfunction. They still have a high vasopressor requirement, inotropes, decisions made to escalate to percutaneous mechanical circulatory support, but despite that, the patient gets worse. And so overall, the main sort of difference is this first patient has sort of a classic response with a low cardiac output and high systemic vascular resistance. The second patient has a low cardiac output, but surprisingly or potentially unexpectedly low systemic vascular resistance. So they're both manifesting features of cardiogenic shock, but also vasodilatory shock. And in the first patient, mechanical circulatory support helped. The second patient, it didn't. And we were sort of looking at these cases with frustration because we looked at the kind of overall design of clinical trials that had tried to evaluate whether these treatments may work or not. And the overall group effects in all comers with cardiogenic shock with myocardial infarction really didn't look like there was a benefit. But we were seeing that their patients really were quite variable, and could imagine that in some patients, restoration of cardiac output was the primary problem. In other patients, it was more related to fixing vasoplegia and restoring cardiac output. All the while as well, on the far right-hand side, it sort of emphasized our frustration that the persistent mortality from cardiogenic shock remained upwards of 30 to 50%, depending on the etiology, and really fairly stagnant over the last several decades. We asked whether or not that vasoplegia and systemic inflammatory activation in a subset of patients could be just tracking on the severity. Maybe these patients have been sicker for longer and the multi-organ dysfunction had set in some spiral of illness severity that had accelerated. But when we looked at the correlation between markers of systemic inflammation for the red bars there and the presence of those versus the absence of those, you can see even as we stratified patients based on illness severity, it tracks it, but it's independent of it. So it did seem like there was some other component to this in addition to risk and severity. We thought maybe it was mechanism, and so we profiled the leukocyte transcriptional response to STEMI, and indeed found that there is a proportion of patients that really activates a lot of pro-inflammatory and immune activation pathways in response to myocardial infarction. There's another proportion that shifts towards more of a fibrotic and kind of pro-platelet activation, coagulation type pathways, and sort of a healing kind of pattern. And so we were sort of seeing that there was evidence for this. It did look like there might be some component of their variability in clinical presentation that related to risk. It also looked like there might be some component that related to a mechanism of disease, or the kind of what we might call effect. And you can imagine that if we were to try to design a clinical trial, we'd want to account for this. And so we'd want to account for the fact that treatments might work differently depending on the patient's risk and depending on the mechanisms driving their poor outcome. And so we could look for tools to stratify risk, as the kind of pro panel on the left shows. We can certainly find them if we look, obviously. And then on the right-hand side, this idea that maybe we could use clinical trials, such calling on kind of techniques called predictive enrichment, to try to say, you know, in which particular patient is this mechanism of disease active that we're targeting with the treatment that we're trying to provide. And I'll provide another example of this concept now, and again, in critical illness. This is now a 65-year-old woman with pneumosepsis complicated by hypoxemic respiratory failure. She has a P to F ratio and bilateral airspace opacities on her chest X-ray that qualify for ARDS, requires invasive mechanical ventilation. She on exam is warm, she has moderate vasopressor requirement, and she has evidence of gram-positive bacteremia, suggestive of Staph aureus in her bloodstream. She's treated with antibiotics, low tidal volume ventilation, reduced conservative fluid strategy, high PEEP, but despite all that, she continues to get worse, unfortunately. A second patient, also 65, pneumosepsis, respiratory failure, same degree of respiratory failure, in fact, but now she's cooler, she's got a lower vasopressor requirement. She again has evidence of positive blood cultures, treated with the same regimen, and with those treatments, she improves. And so this first patient has sort of a hyperinflammatory response with immune activation and evidence of more of a SIRS component. Second patient has more of a hypoinflammatory response, and they both overall obviously have hypoxemic respiratory failure. They would both be considered sepsis-induced ARDS, but they have very different kind of clinical trajectories over time. And it raises questions about whether fluids may have helped one patient hurt another, whether PEEP had an impact on outcomes, and then maybe someone asked on rounds of steroids could help, which is a good question. Again, frustrations in respiratory failure and in sepsis related to the same kinds of challenges, just that patient populations are much more diverse than the clinical trials that we currently study them in are suited for. In this population, obviously, we have a lot of risk tools that we can use to stratify patients with respiratory failure or with sepsis, in this case, showing the sequential organ failure assessment score. And on the right-hand side, this idea of mechanism or effect. Is there a subset of patients that progresses to a hyperinflammatory response and another group that suppresses to an immune suppression response? In fact, we think from leukocyte transcriptional studies and others that there are. In fact, we think that about 40% of patients with sepsis actually have more features of immune suppression than they do of immune activation. So you can imagine trying to find which patients would benefit from immunomodulatory treatments has been quite difficult when we don't have adequate resolution of the sort of mechanisms in play in a particular patient. On the left-hand side, what if we could design trials? This is a neat secondary analysis of an older activated protein C in sepsis trial, showing that as patients' risk for mortality increases, the separation between the two treatment groups of placebo in gray and the treatment group in white increases, suggesting that there may be some degree of variability in treatment response as a function of underlying risk. In this secondary analysis on the right-hand side of a simvastatin in ARDS trial, overall the trial didn't show any benefit of simvastatin in all comers, but when agnostic clustering methods were used, applied to biomarkers and clinical physiologic data in the patients, those techniques pulled out a hyperinflammatory subgroup as well as a hypoinflammatory subgroup. The hypoinflammatory subgroup seemed to do better with ARDS overall, but the hyperinflammatory phenotype, interestingly, seemed to respond to simvastatin, and they in fact had an improvement in outcomes with simvastatin, which is in this case acting to suppress systemic inflammation, whereas the group that had the hypoinflammatory phenotype did not. And so you can imagine designing a clinical trial. If you wanted to study simvastatin again, which we are doing, you'd want to just identify those patients that have that hyperinflammatory subphenotype, and you'd want to try it in those patients. The same for other immunomodulatory strategies. So that's what was going on back in 2000 up until March 10th on 2020. On March 11th, obviously, a lot changed for the world, and we were rapidly confronted with the COVID-19 pandemic. And very early on, it became apparent that some patients got sicker than others, and some of it seemed to be a function of exposure and the sort of dose of the virus that patients received from each other. But some of it seemed to be related to each patient and each individual beyond their comorbidities and beyond their level of exposure. And so that question really sort of stood out very early to us in the pandemic about why some people get COVID get sicker than others. Like many, we were really sort of urgently trying to find treatments for this new disease. And at the bedside, we were noticing from a cardiovascular standpoint that there was a high proportion of arterial thrombotic events, myocardial infarction, stroke, arterial thrombosis. We noticed a strong correlation between troponin as a marker of myocardial injury and excess mortality. In the ICU, on a respiratory standpoint, we noticed that patients had a bit of a different profile with increased dead space, hypoxemia absence, significant increases in pulmonary elastance. In other words, the pulmonary compliance was lower than was better than would be expected for the degree of hypoxemia and compared to conventional ARDS. We also noticed hematologically real high risk of venous thromboembolic events, marked elevations in D-dimer, as well as hypercoagulability. And there were a number of reasons to think that heparin may benefit those pathways. Of course, it's an antithrombotic. It would have those direct sort of effects on the thrombotic and immunothrombotic cascade. There were reasons to think it might be antiviral. It caused conformational changes in the spike protein, which impaired the virus from binding to host cells. And it has direct anti-inflammatory effects that we in cardiology think of all the time. In fact, we think that's a lot of its benefit in terms of its downregulation of IL-6 and other mechanisms. But again, we were sort of facing this disease that looked like there was really a considerable amount of variability clinically. And we were asking ourselves, how do we find the right patients in whom to try to block this immunothrombotic response? Is it a function of severity? Is it a function of a particular pathway? How do we kind of design a trial that reaches the right patients with this treatment? And so we wanted to ask this question again about how to design a trial around these principles of heterogeneity, which sort of fit with what we were seeing at the bedside, and also some of the other challenges, of course, that pandemic presented. Really also sort of necessitated a change in how we generated evidence. And although we think that those were sort of more apparent on a shorter time scale, I do think that the implications hopefully extend beyond, and we'll talk a bit about what those are. So we'll start by, at least back in 2020, what were we thinking the challenges were, and we'll talk about what the solutions might have been. The first challenge was this idea that we really didn't have any basic prior data. We frequently have limited data in doing clinical trials, or we got poor quality data for informing the trial. But in this case, we really didn't have very much data at all. And so avoiding those shortcomings and identifying control event rates and expected treatment effects, all of the variance in the treatment effect, excuse me, all the things that we used to design a trial was something that we needed to overcome. We also had challenges about equipoise, and this idea of balancing learning while doing, or the exploitation versus exploration trade-off. This was this idea that we needed to institute treatments in a way that helped patients at the bedside in front of us, but we also needed to continue to generate evidence. And dealing with those kinds of balances and equipoise is always challenging, but it was particularly challenging during the pandemic. And this quote is a little bit wordy, but I think it really illustrates the concepts that were present at the time. It's from the New York Times back in 2020. It says, many clinicians on the ground felt the urgency of treating the hundreds of patients dying in front of them. Researchers with their literal and intellectual distance from the ICU were pressing them to think about the thousands of patients that were sure to follow, to slow down long enough to build a body of evidence that they knew with more certainty could help. These tensions have always, between these two ways of thinking about medicine, have always existed. But during the early months of the pandemic, the disagreements provided another layer of painful stress for some doctors already near their limits. And so this idea of really sort of trying to figure out what the right balance is between asking questions, but sort of instituting what we think to be the best care is really very, very important. We've talked a lot, excuse me, at the beginning, pardon me, about heterogeneity of treatment effect, in this idea that treatment's effects could vary on the basis of severity or risk, as well as on the basis of mechanism or effect. And even though we look at group effects in clinical trials, what we'd like to do is recognize that some patients are probably helped, some are probably not net influenced, and some of them might even be harmed by treatments. And so we overall want to try to get at this idea that move from what we look at as conventionally clinical trials as average treatment effects to more individual treatment effects. We obviously have a real need to make this happen quickly and to come up with sort of operational ways to do this quickly. And then there's this challenge of sort of disentangling complex care. We know obviously that studying one intervention in isolation is really quite difficult, and in sort of experimental settings, it's something that we can do. But in clinical practice, there's so much that goes on at once, particularly when patients are sick and there's a lot of concurrent treatments happening, particularly during a disease course where things are changing very quickly and anticipated to change very quickly. How do we sort of track the influence of treatments, the interactions between treatments? Does one treatment work in the presence or absence of another? Disentangling that complex care and protocolizing standard of care really becomes very, very important. And finally, this idea of trial conduct, it's been compared in our conventional way of doing clinical trials is sort of like building a stadium each time we play a new match. Really, how do we sort of pivot to something sustainable where we could increase sustainability and efficiency by building an infrastructure that hosts multiple matches over time. So what would the ideal trial look like? Well, we turned to Bayesian adaptive platform trials as one potential method for looking at this. we'll break down a little bit what that is by looking at each term. So what does the term adaptive in a randomized clinical trial refer to? Well, most clinical trials obviously start with a fixed design, then they conduct the trial and analyze the trial. Adaptive designs imply that key features of the trial are modified during the trial in response to accumulating information for the purposes of maximizing statistical efficiency or achieving better outcomes for participants. And so pre-specified rules are put into place that say, depending on what the trial's finding, it will be applying some of these rules that are essentially allowing it to adapt to accumulating knowledge and to learn and be a more intelligent and nimble infrastructure that optimizes statistical efficiency and treats patients and within the trial as well as outside the trial better. And some examples of that can include response adaptive randomization, sample size reassessment, group sequential stopping, two-phase designs or two-stage designs, enrichment designs, multi-arm designs, dose-finding phase 1 designs. And so on the right is an example of response adaptive randomization. So this is a trial that has a group with 4 treatment arms. One of them is the control, that's the C, excuse me. And it has 3 candidate treatments. In the beginning, it starts out with fairly balanced randomization. And then as the trial proceeds, it alters the randomization, the allocation ratios in response to the fact that it looks like treatment 1 is not working quite as well. It looks like treatment 2 might be starting to work better. It reaches an interim point here where treatment 1 is found to be ineffective and is removed from the trial. And treatment 2 in the meantime is looking increasingly effective. So more patients are allocated to treatment 2, which is subsequently found to be effective. Treatment 3 looks like it has a more modest effect, and so it is not prioritized as much as treatment 2 is. This allows patients in the trial to receive treatments that are more effective or have an increasing level of evidence to suggest their efficacy. It also allows results to be generated more quickly for the benefit of patients outside the trial because it prioritizes treatments with better interim evidence of efficacy. And it allows treatments to be sequentially removed and added from the trial. That gets into the idea of what a platform trial is. This implies the use of a master protocol as a foundation to study multiple treatments for one disease. So the master protocol might, for example, enroll a population of patients with heart failure. They may randomize them to a standard of care or a number of interventions, as we just saw. They may perform group sequential assessments to determine whether the treatment has met the criteria for effectiveness or ineffectiveness at iterative assessments. And so the first treatment here is found to be ineffective, treatment 3. It's removed from the platform. At the same time, treatment 2 looks more effective than treatment 1. So the response adaptive randomization alters the allocation ratios, favoring more patients receiving treatment 2. Eventually, at another interim, it graduates and it now becomes the standard of care. The standard of care is dropped, the original one, and now the treatment is compared to that as the standard of care. And in the meantime, a 4th intervention is now added. And it creates a platform for perpetual learning such that one trial is able to study multiple treatments through a iterative and perpetual mechanism. The Bayesian component of this is not required for adaptive platform trials, but it is often used. It has the advantages of being naturally sequential and revising and updating probabilities as information accumulates within the trial. And it really sort of uses this idea of a pretest probability or a prior probability. It takes evidence, and it does this again in an iterative way to alter what the likelihood of a treatment effect is based on the prior. And then it generates a posterior probability, which reflects the strength of belief in the treatment's effect over time. One can design these ways in such that looks at the prior as being neutral. In other words, that it has an equal probability of being effective or ineffective, or it could be a prior that is thought to be based on another trial or other data already showing signs of some evidence. And so maybe this is something that's looking to confirm that. We can start out with a prior that's informative if that's more relevant. It also has the advantage of being more akin to how clinicians think. And I think that's well illustrated for some of the trainees that may be at rounds today by this idea of sort of, how we think about stress tests as cardiologists. And so the idea of a stress test is that we sort of take a pretest probability and we modify it based on the likelihood ratio or the treatment or the evidence rather from the diagnostic at each step. We derive the likelihood ratios on the basis of what the findings from the stress test is showing. So if this stress test doesn't have a lot of changes in the ECG, we say, well, that lowers the likelihood that this patient has coronary disease. In contrast, if they've got some changes, it increases it a bit. If they've got a lot of changes, it really increases it a lot. And what's important about the stress test is that we use a couple of different components of it. So in this scenario, for example, the treadmill will start out. Maybe we start with a 30% pretest probability based on clinical history. We think this patient's got a 1 in 3 chance of having heart disease. Let's say the patient has chest pain at 5 minutes, and so we say, okay, well, the likelihood ratio is now 3. We've modified our post-test probability. It's now 60% based on that initial test finding. We then will generate a revised pretest probability for the ECG component of the test. So we've looked at the clinical component, now look at the ECG component, we'll start at 60%. And here maybe there's equivocal findings. The ECG doesn't show much, or we see some equivocal changes. And so maybe our post-test probability doesn't change in response to the ECG part. On to the myocardial perfusion imaging, we start with 60% based on the last test. This is more convincingly positive. Now our posterior probability is 90%. And so through this iterative revising of our pretest probability, we've now come to a conclusion as to what we think the likelihood that this patient has obstructive coronary disease is. And this is obviously something that we do for all of our decision-making clinically when we kind of are progressively revising our clinical opinion on a patient in response to accumulating information. So it would make sense that a clinical trial would think in a similar way. So what did our clinical trial look like here? So, so we designed this clinical trial to evaluate the efficacy of escalated antithrombotic therapies in patients with COVID-19 who required hospitalization. And I called the trial the ATTACK trial. I want to quickly acknowledge my partners in crime, Dr. Ryan Zarchansky, and Lawler, who I had the privilege of being co-PI with, as well as Dr. Emily McDonald, who was really a critical member of the steering committee and really a catalyst for so many of the important components of the trial, as well as the CanVector network that really supported the trial's initial efforts to get funded, as well as its subsequent recruitment, and is continuing to support future iterations of the trial. So what we were interested in doing is looking at the idea that the treatment effect of therapeutic heparin in patients hospitalized for COVID-19 might vary based on clinical risk, as we've talked a bit about that idea. But we thought it might also vary based on some marker of efficacy or some marker of mechanism. So to assess the possibility that it varied based on risk, we stratified patients into a moderate group who were patients hospitalized on the ward, not in the ICU, but they were still requiring hospitalization. And then a severe group. The severe group were patients who were critically ill in the ICU. We also stratified the moderate patients based on what we thought might be a pathway marker of clotting activation. So the D-dimer is obviously a plasma fiber degradation marker that could suggest patients with increased risk of thrombosis, or patients in whom intravascular thrombosis is already active. And that might be a group that particularly benefits from the treatment. So, but there were reasons to be unsure about that too, because there was this idea that the increased capillary permeability might reflect the opportunity for D-dimer to be generated outside of the vessels in response to tissue factor binding, and then enter the bloodstream and be elevated just on the basis of the permeability and the extravascular clotting. So it wasn't sure whether or not D-dimer would modify the risk. And we overall wanted to get at that idea. Maybe there's a difference between treatment effect and illness severity. Maybe there's a difference between treatment effect based on the D-dimer. And so we stratified patients into these clinical groups. We allowed, and we specified stopping rules. So we said if the treatment's found to be effective, in other words, if there's a more than 99% chance that it has a beneficial effect, we'll say it works, and we'll stop enrolling that group of patients. If there is a less than 5% chance that there's more than a 20% improvement in our primary outcome, which was a composite of ICU therapies and survival, then we would say it's pretty unlikely to have a meaningful benefit, that we'd be able to translate it. We're not going to chase it further, we'd stop enrolling. It would be challenging to do that if we just ran 4 separate trials, and it would be a limitation to the power of assessing these outcomes to do this all independently of each other. And it would sort of seem a little, I don't know, sort of be blind to the idea that, in reality, the treatments may not vary. And so it would be setting a really high bar to require the treatments to independently benefit, independently demonstrate efficacy or not within each group. Maybe there's a way to sort of accelerate the knowledge generation. So we employed statistical techniques called dynamic borrowing, which I'll just quickly illustrate here. This is this idea of statistical shrinkage. And so it's this idea that when we look at subgroup effects, we look at them completely separately, or we look at them as a completely pooled effect. In conventional clinical trials, that's what we do. We typically do the overall pooled effect for the trial, and then we post hoc, or at the end of the trial, break down the subgroup components based on, diabetes or absence or presence or other kind of risk factors, say. But what we'd like to be able to do is actually to have those groups communicate more information with each other. And we'd also like to account for the idea that we would probably better estimate any individual subgroup effect by considering what the treatment effect is in the other groups. And they've simulated this as sort of an interesting analogy in baseball. When they try to estimate a player's batting average, they show that if you look at the mid-season batting averages, you could better estimate the final batting average for any player by looking at their average in the context of the rest of the team's performance. And it really makes a lot of sense that outlying treatment effects would potentially be spurious and would gradually regress to the mean. So what dynamic borrowing does is, depending on the degree of similarity between the initial treatment effects and the subgroups, it'll move those treatments together and it'll increase the power. And so you can see that the size of the little circle increases a little bit here. In this case, it's brought the treatment effects together a little bit, but it hasn't made a big difference. In the second scenario, they were more similar to begin with, and now it's brought them together and it's made a larger difference. It's increased the power, and it's essentially come to the point where they sort of said, look, they're all pretty similar, and it's accelerated a trial conclusion. So we do think that this is a method that sort of gets around having to do 4 separate trials by allowing the groups to communicate to each other on the basis of the degree of similarity in the treatment estimates. So the trial performed its first interim analysis in November. It then performed one in December, which found a futility conclusion in the critically ill patient population. And if anything, looked like the treatment effect actually was in the wrong direction. It looked like a favored harm, but it certainly didn't look like it was a benefit. And so the next day, that information was able to be disseminated and shared, and clinicians could inform their practice with the top line findings, and then obviously with the subsequently more complete findings. At that time, also response adaptive randomization was applied in the 2 moderate or non-critically ill patient populations. The following month, the treatments were found to be superior in both of those moderate D-dimer high and D-dimer low groups. And at that point, the trial stopped. The results were published a year or 2 ago now, I guess, a year and a half ago. In critically ill patients, as I mentioned, it looked like, if anything, the treatment effect favored harm, certainly non-beneficial. In non-critically ill patients, it looked like the treatment was effective and led to a 27% reduction in patients' ICU therapies and survival as a composite, which corresponded to a 4% adjusted risk difference in survival without needing ICU with that treatment. It looked like it reduced the number of the components within that overall outcome. It was an ordinal outcome. The organ support reduction was driven to some extent by mechanical respiratory support, as well as to a lesser extent by reductions in intubation, with a modest but 87% probability that survival was improved. So overall, how did this trial do addressing the challenges? Well, it addressed the shortcomings of prior data by performing well in the face of unknowns. It was less reliant on initial trial assumptions, less reliant on type 2 error, or less prone rather to type 2 error. We hope many trials finish with an inconclusive result because the sample size was too small for what ended up being the observed effect in the trial to meaningfully draw a conclusion. Adaptive designs can potentially get around that limitation. This idea of equipoise, balancing learning while doing, the trial learned and adapted while incorporating new knowledge, and, for example, applied response adaptive randomization was something that we found clinicians initially to be a bit hesitant to participate in the trial because people were forming opinions very quickly. And then when we said, well, the trial is going to adjust the allocation ratios as it's going along, depending on what it's finding, and that really relieved a lot of people. I think they felt like there was a sense that patients in the trial were going to be getting what was thought to be, at least as the trial progressed, to be the best available evidence. The trial was able to generate knowledge sequentially as conclusions were obtained, and, as I say, to disseminate the results in sequence and not sort of all at once. It also allowed us to study multiple interventions at once, and the platform infrastructure, which I didn't spend a lot of time on, but allowed us to randomize patients to more than one effective treatment. We'll talk about that in just a second. The heterogeneity that we talked about, I think was, and which has sort of been a challenge in critically ill patients, has been finally sort of addressed by this idea of looking at heterogeneity in outcomes. Patients were able to be dropped, the patient groups, I should say, were able to be dropped or retained based on whether there was a group treatment effect or not in that particular subpopulation. How do we make this happen quickly? Operationally, we were able to partner this with other trials, which is give you a quick second. Okay, sorry about that. So how to make it happen quickly? As I say, we really partnered with other groups to accelerate that. I didn't spend a lot of time on that, but we can talk more about that in the question period if it's of interest. This idea of looking at treatments in isolation, we were able to protocolize what became many standard of care treatments and to test treatment interactions. That was something that was really beneficial in the platform design. And finally, we catalyzed, I think, through this trial and other related efforts, the genesis of several platforms which continue to generate effective evidence in the pandemic and beyond. One of them is the REMAP-CAP adaptive platform trial that I have the privilege to be involved in a number of ways, and has now studied over 60 treatments in a total of 12,000 patients, with an average number of treatments studied per patient of about 1.7 or so. So most patients receive many patients, I should say, at least receive more than one potentially effective experimental treatment, which is a potentially more ethical framework for participants in the trial. A single trial has been able to study more than 60 treatments and to generate foundational evidence in terms of interleukin-6 receptor antagonists, hydroxycortisone, as well as plasma, convalescent plasma, and antithrombotic therapies in addition to anticoagulants. So in the last couple of minutes, I wanted to just think a bit about where to take these ideas next. And I think we've sort of at a very exciting time in thinking about acute care medicine, at least in cardiology and in critical care, because we sort of have evolved through these different stages of a foundational component with physiologic changes and sort of defining syndromes based on severity risk scores, to what we think is now more of a precision medicine environment, where we do actually have better availability of a number of diagnostic tests, molecular omics tests that are able to stratify patients into some of these different mechanistic subgroups that we're interested in. And it helps us to design clinical trials that might be more effective and more individualized. And so we've looked largely in the example that we saw earlier in the talk at this idea of an umbrella trial, where we take one patient population that has a single disease and we break them down into different subtypes, and we look at one particular subtype which may be defined on the basis, as I say, of risk, or it may be defined on the basis of potential treatment effect and mechanism, and then we study treatments separately within that. We have also this idea that maybe we could even flip that around the other way. Maybe we could take patients that have multiple diseases, but they've got a shared treatable trait across those diseases, and we are able to target them with one effective treatment that overall improves outcomes. And these approaches are used in oncology and provide a great example framework for how they might be applied in acute care medicine as well. But very much in oncology, obviously the focus is on staging, and so the focus is on applying something like TNM to stage the patient overall, and then the focus is on subphenotyping, evaluating the potential disease driver. So as an example, in a patient with melanoma, they might have stage 3A malignancy, T2A and 1M0. It may be a superficial spreading or acrolentigo or lentigo malignant histologic subtype. And then they will potentially it will be definable on the basis of its oncogenic driver. So it may harbor a mutation in BRAF V600E, a MAP kinase activator that is a promitogen and contributes probably to about 10 to 15% of cancers overall. And so patients can be sort of broken down into components on the basis of illness severity. It may not make sense to do surgery for stage 4 malignancy in general. It may make sense to treat patients with a BRAF V600E mutation with a treatment that targets that, such as bemorafimab. And overall, this exciting idea, like to take it towards a basket trial framework, where we say, well, if BRAF V600E is in fact in 10 to 15% of malignancies, maybe we could even study patients that have non-melanoma cancers and potentially trial these interventions in these patients. And that's something that I think is really very exciting. It sort of flips this basket trial idea around and says, could we introduce an intervention that prevents multiple diseases? And so an example of that, I think, in recent clinical trial work has been in the evaluation of canakinumab, which is an IL-1 beta monoclonal antagonist, in the prevention of atherosclerotic cardiovascular disease. And so this was looked at in the CANTOS trial a couple of years ago. What was interesting was that the treatment was effective. It did reduce the primary outcome, which was a composite of major adverse cardiovascular events, and it looked like it was effective in slowing or retarding the development of atherosclerotic cardiovascular disease. Interestingly, the reduction in C-reactive protein on treatment was proportional to how much patients benefited. So patients that had a greater reduction in their C-reactive protein had a greater benefit with the treatment. So it really speaks to this idea that we could use biomarkers both to stratify patients, but also to stratify patient response to treatment. But I think the key component of the trial that was really very exciting was the investigators hypothesized that interleukin-1 data and its interaction with the NLRP3 inflammasome really was a common mechanistic linchpin, not just in the development of cardiovascular disease, but also in the development of lung cancer and arthritis and a number of other clinical diseases, and accordingly pre-specified all of those outcomes that the treatment with IL-1 beta receptor antagonist would reduce those outcomes overall. And in fact, it did. It reduced bronchogenic lung cancer incidence. It reduced multiple forms of arthritis. And overall, this really exciting idea that, although we've very much defined diseases syndromically, and we've defined them based on their clinical manifestations at the bedside, the systems medicine framework might help us appreciate that, in fact, a heart attack, cardiac arrest, bronchogenic lung cancer, and multiple forms of arthritis actually are, in fact, overlapping diseases in the sense that they're all driven by one particular mechanism of the NLRP3 inflammasome in this case. It's an exciting idea that I think is well encapsulated in this quote from Joseph Pascal's and Elliot Antman. Many traditionally defined diseases have common mechanisms. Therefore, eliminating siloed approach to medicine might ultimately pave the way to creations of universal precision environment. A lofty ambition, but something that we seem to be getting closer and closer to. If I've spoken too quick or not quickly enough about any of these ideas, these are some of the recent kind of perspective pieces that we've put out around these ideas of risk stratification, taxonomy, and critical illness, new approaches to evidence evaluation that we've learned from COVID and carrying them forward, and then stratifying patients better to individualize care. So in conclusion, overall, critical illnesses are heterogeneous. There's quite a bit of patient-by-patient variability that is probably not captured well in conventional clinical trials, but there are approaches and newer approaches to doing clinical trials that might work better for this. Many challenges were highlighted by the pandemic, but are probably relevant broadly beyond. I think we appreciated that the pandemic really was a compressed timeline for what is a lot of, I think, compressed timeline for what really is the narrative for a lot of clinical research overall. And I think there's opportunities to leverage the lessons that we've learned beyond infection, obviously. Bayesian adaptive platform trials seem to overcome a lot of those challenges, and I do think they could be new models for evidence generation, especially in acute care medicine where solutions are needed. And finally, future directions. I think we spend a lot of time on it now, but I think this idea of common treatable traits, my particular interest are in the intersection of cardiovascular disease and infection. I think there are opportunities to leverage treatment and prevention of both of those using systems medicine frameworks and adaptive trials. It'd be exciting to talk more about that hopefully one day. So, thank you very much.
Thank you so much, Dr. Lawler. Thank you, Patrick, for this wonderful presentation, very innovative way of approaching research, which we're hoping, obviously, for you to bring to the MUHC. I'll invite people to enter questions in the chat. Can you just explain, I'm trouble understanding a little bit the learn by doing. Can you just explain that to someone who's obviously hasn't seen this before, please?
Such a great question. You're right. We went by very quickly. It's this exciting idea that we sort of are balancing what's sometimes referred to as the exploration exploitation paradox. And it's this idea that we all think we should implement what we think is the right thing to do, but we also need to sort of be aware of the need to evaluate evidence in many cases, what we think is the right thing to do doesn't have been the right thing to do, obviously. But so it's this idea that if we could come up with clinical trials that more seamlessly or sort of that form a tighter symbiosis or harmonize better with our current approaches to clinical care, that we could create an environment that allows us to appreciate more, a little bit more, whether or not the treatments are working, in the sense that what we would do, for example, is apply something like response adaptive randomization, where we would say, this patient is going to receive what is thought to be, as the trials accumulating knowledge, increasingly the effective treatment. And so it's this idea that although we're taking part in the clinical care and we are, using our judgment to care, we're allowing the trials or the trial infrastructure some autonomy to make decisions as it's going along, and we're trusting that that's leading to the better treatment of patients in the trial. And so it sort of tries to get at the idea of equipoise, because it's often the case that people have strong opinions one way or the other, and in a more sort of level playing field, maybe this gets around some of those considerations. I don't know if I've answered it well or not, but it's
absolutely. Before I get to the questions, Mark, you have a comment. I believe I'll let you take your.
Sure. Thanks. Thanks, Patrick. That was a fantastic presentation, and congratulations on great work. And we're thrilled to have you join us, and looking forward to having you here at McGill. So, Patrick, as I grew up as a trialist 20 years ago, the prof that taught me interventions said the top 3 threats to completion of a randomized trial were recruitment, and recruitment. And over the course of my career, I learned as trials became increasingly regulated that the top 3 threats were contracts, regulatory approval, and then maybe recruitment. And it seems to me that umbrella trials at least might help tackle threats 1 and 2, but I'd like to hear about your experience in that regard.
It's a superb comment on so many ways. So I absolutely agree. I think was exciting for us during the pandemic that things happened so quickly, because it showed that it is possible for things to happen quickly, even if that's not business as usual with a lot of the competent authorities and regulatory frameworks that we operate within. One of the things that I think could be worth thinking about is this idea that, for example, within REMAP, it's a master protocol that's approved to study patients with pneumonia. And when new treatments are added, when a site signs on to participate in the new intervention evaluation, the contract that's with that site, between the site and the sponsor, is amended. It's not totally started from scratch. And similar to the original approval, healthcare approval, it's amended. It's not started from scratch each time. So there are, and same for the consent process too. The consent is modular, and it'll have a sort of fundamental component, and then there'll be modules specific to the treatments. And so it really does save, I think, has the potential at least to save a lot of time on those steps, because I really agree that that's so frequently the delay. And the idea that, trials could be put together that study 60 plus treatments in one trial, I mean, there's many, many opportunities for efficiency. But I don't know if I've answered that well. Your comment was absolutely superb.
So, Patrick, there are lots of questions in the chat, so we'll do a rapid fire questions here. When we explain RCTs to patients, we say that the choice of treatment assignment is left to chance, flipping a coin. What language do you explain adaptive trial design to prospective participants?
That's a good question. It's a great question. So, and we're still figuring out the right way to do it. I think there are acknowledgements for certain treatments that the adaptations might favor them receiving a treatment with increasing level of efficacy. There are sort of general provisions that the adaptive design will helpfully help us reach conclusions for certain treatments sequentially, and that might mean that a particular subgroup of patients that's found to be working or it's not going to be working, and that would mean that we could generate evidence more quickly. So we do, in some cases, there is some information in there on how what the adaptive design is doing that might be advantageous. But in general, the consensus, at least I've been part of, are largely sort of focused more on the treatment itself and potential, participant risks and things like that. But But it's a good question, and it's something that is its own science in itself. And I think it's a hugely important area that needs more work.
Sandra Dial wants to know, another source of heterogeneity is the timing of onset of acute insult to when we see the patient. Are there research methods to help with this?
What a great question, Sandra. So what's really neat, I think, about some of the, at least in sepsis, some of the leukocyte endophenotyping studies around the leukocyte transcriptome is that they've looked at crossover and stability of the subphenotypes over time, and there certainly is some crossover, and there's certainly some dropout from one group to another, but there's a lot of stability too, and the crossover occurs in both directions. And if it was just a kind of natural history sequence that was playing out the same in all patients, then we would think that it sort of would only cross over in one direction as people are getting sicker, say. But what's neat is it does sort of switch in both directions. When it switches, it's generally fairly stable. For sure, that's so all that to say, I think to me at least does support that there are innate differences in host response to some of these triggers that are probably real and that aren't just a function of timing. But within how do the methods capture the timing, it's a great question. I think what we haven't done, but what we haven't done, but what one could do is one could sort of stratify the kind of duration of symptoms, or the kind of, some other measure of time to sort of see if the treatment effect varies by that. To some extent, that idea was, it's not per se the duration, but it is kind of the question about severity was looked at in the DAWN trial, which was a trial of mechanical thrombectomy and ischemic stroke, patients with ischemic stroke. And it was an adaptive design also. They used group sequential stopping. And in that case, investigators had pre-specified that the treatment effect might vary as a function of infarct volume. And so the treatments were evaluated in patients that had small infarct volume, kind of mid-size and large. And they were fairly agnostic, the investigators had designed, to which group might benefit. They said maybe a small stroke isn't going to work. It's not going to work very well. Maybe in a large stroke, it will work well, but maybe those patients are too far gone, say. Yeah. Dr. Hall, maybe you could hand. Yes, please.
Yeah. So it really struck me with COVID, because if you looked at the initial Decadron trial, the timing was very different between the severity subgroups, where the ones who didn't do well with Decadron, who weren't on oxygen, were randomized much earlier than the intubated, who were randomized much later. And everybody focused on the severity and less so on the timing. And I wondered about that again with the heparin trial, because what happened after your results were published, if there were people on the ward who had received heparin, and then they got sicker and came down to the ICU, it was stopped, which I don't think is what your study was saying. That's why this to me was, maybe COVID brought this out bigger than we had thought of before, but thank you.
Thanks, Sandra. Really great point, great question. And you're absolutely right. There's sort of a pragmatism, I guess, to sort of saying whether it's severity or timing, here's the patient in front of me, and kind of grouping them clinically. But I absolutely agree. I think that wasn't covered. You're right to the specific point that in our trial and in others, the treatments were continued generally. If patients went to the ICU, we analyzed those patients as if they were in the moderate state, even if they spent more time in the ICU than on the ward, say. But interestingly, we've done some secondary analyses and things that do sort of support that may make sense to stop the treatment when patients become critically ill, but it's still in development. And it's all secondary, obviously. Yeah.
I'll just move on to the next question. Kaberi Deskupa is asking, in adaptive trials, she has an uncomfortable sense that there's a higher potential for bias than in a conventional trial. When treatment arms drop out or are promoted within the trial, could this sort of self-reinforcing a potentially spurious difference? Does that make sense?
It does. It's a really good question, Dr. Deskupa. And it's a good point too, that I think in this talk, I didn't spend as much time on that as I probably should have, but protecting against bias, of course, in all trials is really important. Protecting against bias in adaptive trials is really, really important, because there's a sense that some of the adaptations could unblind clinicians, patients, et cetera. If we suddenly start seeing all the patients receiving one treatment, that might say, well, this treatment looks like it's working and no one's receiving this one anymore. It's potentially unblinding. So a few things are done to try to protect against that. The first is that all of the adaptations need to be pre-specified. And so they're pre-specified before patients are enrolled. They also need to be overseen by independent groups. In small trials with simple adaptations, oftentimes that's just the DSMB, but in more extensive trials adaptations, that's oftentimes an independent statistical analysis committee, say, who oversees the adaptations and their implementation. But it's absolutely true that it, blinding and bias and things need to be really watched very carefully. In placebo-controlled interventions, that's less of a concern, obviously. In open label trials, it's more of a concern. Some of the things that we now do in, at least in REMAP-CAP, for example, have guardrails on the extent of response adaptive randomization. So we only allow the probabilities to vary by a certain amount. And above a certain point, we think it's too clinically apparent that they've changed. And so we set guardrails on the proportion of our patients that can receive one treatment or the other. But it's a fantastic question. I think it's something that for open label trials, there needs to be careful attention to that in the design phase.
Ariane, you wanted to make a quick comment. Quick comment. Ariane, you're muted. We can't hear you.
Yeah, thank you, Patrick. It's such a pleasure to hear you and to see how you've just exploded and already contributing such a rich body of research. My question to you is there a way to apply this framework to retrospective data in a comparative effectiveness framework? As you know, and you know our data, we have data for over 40 years, and we're developing models to map out trajectories. And I wonder if we could actually apply this in the data that we have to see what would have happened if we had randomized patients to certain procedures at different times to see if those trajectories might have been changed.
That's such a great question, Ariane. I think things like target trial emulation, but more than that, like the sort of inference methods, I think are very, very exciting. I'll admit that it's not my particular focus, and so I'm probably not as up to date as I should be on it. But I do think there's an immense opportunity to think about that. I mean, certainly one way is to think about, to the extent that we can use inference models and observational settings to inform clinical trials, especially for effectiveness questions. I think, the opportunity for the trials and the observational data to sit more closely together. I think oftentimes it's really kind of a two-stage approach, but I do, for example, we're really in the sort of thinking about it phase, but we're looking at some AI-based approaches to see if we can sort of increase clinical trial efficiency. And some of those involve inference methods and observational data, creating avatars for the patients based on the first proportion that have been randomized. And I'm looking to see if we can then accelerate some of the results, some of the conclusions on the basis of confirming them or not based on what's been seen in kind of observational settings. And it's very sort of exploratory, but I think it's a hugely fantastic question.
Patrick, it's coming close to 1. There are lots of questions in the chat. They keep coming in. But I will have to close out the main portion of the grand rounds and ask you if you could please stay on to answer the questions in the chat, if you're okay with that. I'd like to, first of all, congratulations. It's a pleasure to see you. Welcome to McGill and the MUHC. Thank you for that wonderful talk. I'm going to just put a plug, a couple of little comments. First of all, Dr. Verma could not be here, but a great thanks to Dr. Atul Verma, our Chief of Cardiology, for recruiting you. I know he worked very hard for that. So, and a little shout out to obviously Dr. Roger and Alain Vito for creating the Rising Star competition. Dr. Patrick Lawler is the first recipient of the Rising Star Award. And please join us, everyone, on May 11th is the first gala for the Rising Star Award, which will be honoring Dr. Patrick Lawler. Patrick, I invite you to please stay on, answer the questions, nice comments and questions in the chat. Welcome, and thank you again for this wonderful lecture. For those of you who need to go because it's 1 o'clock, thank you for joining us, and I wish you all a wonderful afternoon. And Patrick, I invite you to stay on. Thank you. Bye-bye.
Thank you, Nadia. I will just look through some of the questions that we maybe haven't touched on. So yeah, that was nationwide basket trials of interventions to treat depression. I think that's a fantastic question, and there is some interest, I know, in looking at PTSD and some other diseases with those approaches. Dr. Hutchison, it's nice to see you. I have a lot of fond memories of many of your lectures. Returning to something analogous of ancient humor. Yeah, I think it's really a neat question. There's been such a push, at least in critical illness, to really focus on syndromes and syndromic definitions, and a lot of that is sort of linked with research funding and funding calls around ARDS or shock, or and so there's sort of a need to have some cohesion. But I absolutely agree. I think this idea of looking at disease pathways rather than their final manifestations is a really critical point. It's a very, very great point. Dr. Fantas, difficulty recruiting a number of patients, futility statistically reach superiorities that save time. Yeah, no, it's a great question also from Dr. Fantas, that there is in fact an efficiency, an operational efficiency to this, that treatments that are not found to be effective are dropped from the trial, and patients are more are eligible for treatments that remain in the trial and remain under investigation. So there's certainly an efficiency in that sense. From Dr. Doss, a question: could it be that the underlying factor in better response of non-critically ill patients to heparin might be non-critical state, better immune status, and vaccines? It is a good question, and I think it's a great point that we didn't really get to talk much about, was this idea that the treatment effects might have changed temporally over time. And I think as vaccination and immunity has evolved over the past 3 years, I think it's likely that the effect of these treatments has changed over time. And it's tough in the absence of more contemporary data. We still see these as the best available data, but I think it's a great point. I think somebody could very reasonably repeat these trials and ask whether this is still effective or not, to be candid. Dr. Rosenblatt, revolutionary approaches. How do you explain both positive and negative results to the general public? So it's understood what works and what doesn't. Yes, that's a very, very, very good point. It's a very good point. I think we are increasingly appreciating that communication of research results is suboptimally done, and this, there were a number of learning lessons, I think, through the trial experience, not per se in a bad way, but just in a, how do you do this in the first kind of application way, about, what is the fastest way to disseminate knowledge and best way to communicate research findings to the public. And then Dr. Bernatsky, and great comments also for Argon. I agree, using Bayesian priors can help increase trials as well. So I think that's it for the questions. Victoria, is there anything else? And please, for the I'm terribly sorry for those that are still on the call, if there's any questions or comments, apologize for breezing through things quickly in the end.
There's nothing else for me. If you want to stay on and continue answering questions, go ahead, but if not, all good.
I think we've made our way through the
All right.
chat, but if anyone has any questions, thank you very much for the opportunity to come. Thanks, Sandra. Nice
Thank
to
you
be in
very
touch again.
much.